Thank you. Hello.
Hi.
Hi. So we're going to talk about OCD and anxiety in children today, specifically Connecting for Kids, asked to talk about OCD and anxiety in children ages 0 to 12. It says in the world's tiniest font what science tells us and how we can use it to help your kids. I'm sure that's why you're here. You're looking for some ideas about how we can be helpful with your little ones. So I put this up here. I'm not going to go through all the details of this, but you guys are going to all have access to a copy of the slides. This just tells you some of the people I worked with, some of the training I did, just who am I and why am I giving this talk on OCD and anxiety. The basic point here is that once I was a fully licensed psychologist, I went and did some advanced training in the treatment of OCD and anxiety disorders. I worked at a couple intensive outpatient programs for OCD. That's where people go if they have very severe OCD and they go multiple times a week for treatment. I worked with some well-known authors and experts in the field. They gave me some really good training, and I'm going to try and pass off some of that knowledge to you today. And then, of course, there's always the fun legalese. I am required as a psychologist to read the following disclaimer. The material contained in this presentation, the speech, the slides, the handouts, is for informational and educational purposes only. It is not intended to diagnose or treat any mental health condition. It is not a substitute for psychological treatment provided by a licensed mental health provider. Nothing in this presentation should be construed as establishing a client-psychotherapist relationship between you and the OCD and Anxiety Center of Cleveland. Okay, all this fun stuff. Let's get to why you're actually here. What is anxiety? Anxiety, or really its other name, fear, is a completely normal emotion. One of the things that I think, unfortunately, people have lost sight of is that it's totally normal to have anxiety. It's even totally normal to have a lot of anxiety. It's not necessarily a sign of illness. As with any normal emotion, there's going to be components to it. It includes thoughts, sensations, and urges. Thoughts are worries. If you're an anxious person or if you have an anxious kid, you've probably seen some of the common thoughts start with, what if? What if something terrible happens? What if someone gets hurt? The sensations are part of that fight or flight response, which you've probably heard of before. This is something that evolution has given us. When we feel afraid, our body starts making some changes to keep us safe. Our heart starts pumping faster than before. Our blood pressure rises. Our vision often becomes sharper. We may sweat. Blood starts moving to the extremities, again, so that we can either run away or fight. People get triggered with a fight or flight response with some degree of frequency in normal life. It's certainly not too common to feel panic every day, but if you're driving and suddenly the person in front of you slams on their brakes, you may suddenly feel the fight or flight response kick in. You might feel your heart pounding in your chest. I know I do. Then the question is, how do we distinguish anxiety from an anxiety disorder? I think there's two main things you want to be considering. One is that you're starting to see fear or anxiety in situations in which you tend not to see it in other people. So just like in the example I gave, you slam on your brakes in traffic and the fight or flight system kicks in. That's a pretty normal reaction. But if I'm starting to feel fearful every time I have to go to school or any time I have to touch a doorknob, then we're starting to see a more idiosyncratic fear where maybe not everyone feels that way. Even then, we don't necessarily have a disorder. It really turns into a disorder when the fear leads to a pattern of avoidance that disrupts a person's life. So if I'm afraid to touch the doorknob and now I won't enter the school because there's doorknobs all over the school, now it's really starting to interfere with my life, and now my anxiety is starting to become an anxiety disorder. Okay, we're going to talk a lot about something called safety behaviors. These are really present in all forms of anxiety and anxiety disorders. Safety behaviors are anything a person does when they feel anxious to temporarily reduce their feelings of fear. So these are a more subtle form of avoidance. I gave the example before of someone who doesn't want to touch the doorknob and doesn't want to go to school. But what if I'm willing to touch the doorknob, but only if I can use hand sanitizer afterwards? Now I have a safety behavior. I got afraid of the germs, and I'm doing something to feel better. Or maybe I'm afraid to go to school, but I'm willing to go if my mom comes with me. This is another safety behavior. This makes me feel better in a situation in which I'm scared. Safety behaviors serve to reduce the fear that something awful will happen, right? The hand sanitizer may make me feel like, okay, I won't get sick. But it can also be used to increase the sense that someone can cope with their feelings of fear. And this is like that second example with mom at school, where, having mom at school probably doesn't actually keep me safer, but I feel like if I get scared, I can handle it because my mom's there. Okay. Now, let's talk about some common anxiety disorders you see in young children. Separation anxiety is probably one of the more common ones you see all around. This is any sense of fear when you are away from an important attachment figure. Usually a parent, but it doesn't have to be. The child often will feel like they may be in some danger, maybe they're going to get kidnapped, or maybe something terrible will happen to the parent. This is what you see in separation anxiety disorder. Phobias, I think most people have probably heard of in some form or another. You could have a phobia of animals or a phobia of the nighttime. This is just a specific fear of something. And you do see a lot of animal and sort of nighttime fears in children, and as well as maybe a phobia of the swimming pool. A emetophobia, fear of vomiting, is super common, and a lot of people have never heard of it. They don't know anything about it. But at my clinic, I always have multiple emetophobia cases. It's just so common, this fear of sort of losing control and throwing up. So I did want to put it up there in case anyone had any youngsters with it, so they might, for the first time, realize, oh, hey, that's actually a common phobia that people do know about. Selective mutism is when a child becomes fearful to speak in certain situations. They have the full capacity to speak. There's no issue with their ability to speak, but when they become nervous, they may not be willing to speak because of how fearful they are. So maybe they're willing to speak to their parents, but not to strangers, or maybe they'll speak to strangers, but not to their teacher. But there's certain situations in which they are sort of effectively mute. Generalized anxiety disorder, you can see I put it in quotes. This is kind of a misleading name. People often think generalized anxiety is just, oh, I'm a worrier, I'm anxious about everything. And that's not really the case, even though that's exactly what it sounds like. It's an issue of poor naming. People with generalized anxiety disorder tend to have 3 or 4 different worries that come up a lot. So if I'm fearful about school, and I'm a school-age child, that's going to come up quite a bit, and I may look like I'm just a generally anxious kid, but actually I have one thing that I'm scared of with school. Now, I might also be worried about my parents' health. What if they die? What if they get sick? So now I have 2 things, and again, it's going to come up a lot because my parents are a pretty big part of my life. And maybe I also have some social anxiety about how people are going to judge me. So if you have social anxiety, fear of your parents dying, and fear of school, you're going to get called generalized anxiety disorder, but it's sort of a misleading term because it's not really generalized to everything. It's just sort of that there's a few things that apply to a lot of situations. And then I threw post-traumatic stress disorder in there, again, just for some general knowledge. This is if a child goes through something traumatic. They may develop some symptoms afterwards. Trauma being something life-threatening or very serious, like a sexual assault or something like that. I know a lot of times in common language we use the term traumatic to refer to almost any upsetting event, but in PTSD you're really talking about quite serious traumas, and then the child may have nightmares, bedwetting, and a lot of avoidance. They don't want to talk about it, think about it, or go anywhere near anything that reminds them of that horrible experience. Okay. Now let's talk about OCD and how it's a little bit different from those, but also how it's kind of the same. OCD is a special type of anxiety disorder. It was recently reclassified as its own disorder. This is not super helpful to the general public, but it was done because sometimes in OCD, people get this feeling of distress that's not exactly anxiety. Sometimes it's a feeling of incompleteness, or it could be a feeling of disgust. And so because it's not always just anxiety, they moved it into its own category. But what I'm going to suggest today is that it's most helpful to think of OCD and anxiety in OCD and anxiety disorders as very similar things that respond to almost identical treatments, but they just have different names. Just like in anxiety disorders, the anxiety, or in this case, the distress, occurs in situations that don't typically cause those reactions for other people, and it leads to a pattern of avoidance that interferes with a person's life. Now, in OCD, there's also these repetitive behaviors that are called compulsions. Compulsions are just another word for safety behaviors. They're things people do when they feel anxious to make themselves feel better. And in OCD, they get the special label of compulsion, but it is the exact same mechanism. Okay, obsessions. Why did it get its own name? Obsessions and compulsions are sort of this key factor that led to these different classifications. Obsessions are unwanted intrusive thoughts. They tend to be recurrent, and they come with feelings of distress. Again, not just anxiety, although overwhelmingly the case that it is anxiety, but there can also be feelings of disgust, doubt, or a sense of incompleteness. So this is the sort of, earlier I talked about in the fight or flight response that there's some worries, there's some thoughts that go with anxiety. Obsessions are the thoughts. Compulsions are the behaviors that are done, again, in order to relieve the distress. They're those safety behaviors. They may be observable, or they can be more subtle, like mental acts. A child may count to themselves, and you can't actually know that they're counting. You're looking at them, you don't know they're doing anything, but they are doing something. And those are still compulsions, even though they're harder to see and harder to recognize. Okay. I think these things kind of take real shape when you start to look at examples. Obviously, the most common obsessions and compulsions that people tend to know about are in the area of contamination, cleaning, concerns with germs. A person may touch a surface and then be bothered by these intrusive thoughts of, I have germs on my hand, what if I get sick? What if these germs get inside my body? These kinds of things. And of course, the rituals, the safety behaviors, the compulsions, the behaviors to make themselves feel better involve decontaminating, cleaning, washing, showering, hand sanitizer, all these things to make them feel like, okay, I've neutralized the germ, I've neutralized the threat, so I'm going to feel better now, at least in the short run. Some of these other types, and then I'm going to jump to the bottom real quick. Symmetry is another one that I think a lot of people have heard of. It's sort of, I touched over here, so now I feel like I have to touch over there. You sometimes see this on TV in the movies, or these remarks that it's like, oh, I just need things just so. I need my desk to look a certain way. I would say in children, you tend to see a lot more tapping. Again, if I tap over here, I have to tap over there. Or if I tap on this side of my body, I tap on that. Or I stepped with my left foot, so I have to step with my right. And this is, again, where you're seeing that not just right experience or that incompleteness. They're not always anxious. It just feels like I step with my left foot, something's off, and until I step with my right, it just doesn't quite feel good again. Now I want to talk about harm to self or others. A lot of people have not heard of these types of obsessions and compulsions, but they are super common. Contamination, for whatever reason, has just really made it into TV and the movies, and the other categories have just gone overlooked, probably because they may be a little bit harder for people to understand or perhaps even cause some alarm. What you see in harm to self or others is some things can be magical, where a child may feel like, if I don't say a prayer right now, my mother will die. If I don't, you can even combine them. If I don't tap this 3 times, my dad will get cancer. It could be a stranger too. I've seen cases that are very concerned about famous figures. If I don't do this, the Queen of England will be hurt. Right? So that's one type of harm. There's another type of harm that involves unwanted intrusive thoughts of harming people. And this can cause a lot of alarm for people, but it's a totally normal part of OCD, and it's actually super, super common. It's probably the number one subtype I see at my practice, which is these really intense images about hurting someone else. And they can be graphic and they can be upsetting. They may involve stabbing someone else, strangling someone else. Could be as simple as punching, but that's usually not the case. Could be an image of, I'm walking down the street with my mom and I get a picture of pushing her into traffic. And people get very terrified by these, including the person with OCD, who's more terrified than anyone by these images. And they cause a lot of distress. Why am I having these thoughts? What does it mean? How do I get rid of them? Am I dangerous? Do I hate my mom? All this kind of scary stuff. And it leads to a lot of reassurance. Promise me that I won't hurt anyone. Promise me that I'm okay. So again, this is sort of a little bit different from what most people know about OCD, but it's very common, and I did want to make sure I touched on it. And I also wanted to touch on some of these which fall in the same kind of category, which is less well known and often involve these unwanted intrusive thoughts that cause a lot of uncertainty. So health concerns. Well, I have a stomach ache. Could that be cancer? I have a headache. Could that be a brain tumor? Kids are young, and I know we sometimes think that they don't know about these things, but in some sense they're even worse off because they've only heard a little bit about them. And so any symptom to them may get connected to these things. Same kind of thing, checking, reassurance. Mom, Dad, am I okay? How do you know I'm safe? Will you take me to the doctor and make sure? Sexual concerns, I know, is also kind of tough to hear about in young children, but it does exist, and I think people ought to know about it so they can recognize it. Just like those kind of scary, upsetting thoughts about harm, there may be scary, upsetting sexual thoughts. There may be images of an actual sex act, or there may be words like, oh, what if I hurt my brother? What if I touch my brother inappropriately? Again, there's actually no risk that that's what they're going to do. They're getting these unwanted, intrusive thoughts, and it's causing all this fear for them. And then you also see moral or religious concerns, which is all about, did I do the right thing? How do I know if I'm a good person? Now, normal kids are going to have some degree of distress about these things, but in OCD, they're recurring, they're coming up frequently, and they're causing a lot of problems. It's hard for me to even go to school because I don't know if I'm going to do anything bad while I'm at school. I don't know if I'm going to hurt someone while I'm there. I don't want to be with my little brother because I'm scared I'm going to strangle him. These thoughts are really distressing, and they cause quite a bit of problems for young kids. And then it's also a huge problem because parents have often never heard of these things, and your kid's telling you this, you don't know how to react. So I think it's really helpful to be aware that these are just unwanted, intrusive thoughts. We should take them seriously, and we should participate in treatment for OCD, but we don't necessarily need to respond with fear to these thoughts as the child has. Okay, everybody wants to know what causes OCD and anxiety disorders, and I have a very satisfying answer for you, which is that no one knows. There is absolutely evidence of a genetic, neurological, and some chemical differences in individuals with OCD. OCD has the best genetic evidence of any anxiety disorder, and that's weak, but it's there. Some of the neurological and chemical differences you may already have heard about. Everybody likes to blame serotonin for virtually every psychological problem that exists, which means that either, I don't know what that means. But there's some differences in the serotonin system in individuals with OCD. There's also some evidence in this neurological issue that we all kind of have an error detection system in our brain. That sense that something is wrong and then you take an action to correct it. Especially parents have that. You reach out and grab your child right before he falls off the table, right? There's some sense that something's wrong, and in people with OCD, it seems to be more active. So they're getting this neurological sense all the time that something is wrong, and nothing's really wrong except their brain is giving them that signal. So there's some evidence that this plays a role, but as I said, none of these things are really destiny. They may play a role, they make you more vulnerable, but none of them by themselves means you'll have OCD, and we look at genetic twins, or identical twins who have the exact same genes, the exact same bodies, the exact same brains, and largely shared experiences, and they don't always both have OCD. So clearly, genetics isn't the only explanation. Another thing you should be aware of is something called PANDAS, Pediatric Autoimmune Neuropsychiatric Disorder Associated with Strep. is a mouthful. Some children develop OCD symptoms acutely following a strep infection. So you might want to be thinking about this for your own kids. If your child was completely asymptomatic, got strep, and then developed pretty severe OCD symptoms. If they had any signs of OCD prior to the strep infection, chances are it's not pandas. But you should always get evaluated for pandas. If the symptoms kind of started right around a strep infection, you can sometimes use antibiotics to treat the OCD, although that is actually pretty rare. In most cases, they're going to need behavioral therapy for the OCD, but there are some cases in which a round of antibiotics has resolved the symptoms. Okay. Causes are actually not that helpful. Like I said, it doesn't give us a very exciting or definitive answer. There's something else that's much more important called maintaining factors. This is what maintains the symptoms over time. In other words, why is it that fear or anxiety is getting worse, not better, or at least why doesn't it stay the same? So you can imagine, why is my daughter's fear of germs getting worse? She used to wash her hands a few extra times after using the toilet. Now it seems like she's washing her hands after she touches anything at all. Right, so we're seeing this progressive increase in symptoms. Same thing with a different child. At first, my child was just scared to go on sleepovers because he didn't want to be away from us for the night, but now he won't even go to school for a few hours. So what started as I'm scared of this one tough situation has turned into I'm scared of a lot even sort of easier or more common situations. Why is this happening? Does anyone have a guess? So there is a process of learning that's going on, absolutely. It's unfair I guess it's an unfair question. The whole talk is contingent on it. But you're right. The brain is learning something through experience. Avoidance. If you want to take a small fear and turn it into a big one, avoid it. Avoidance is food for fear. It is the learning that is happening over time. And unfortunately, this flies in the face of virtually every single intervention that you hear about when you talk to just people in general. If someone calls my office, my kid has a fear he was afraid to give a presentation, so the teacher said, no problem, he doesn't have to give it. Let him avoid it, right? The homework was upsetting him because it was hurting his feelings. He was getting frustrated. We're going to modify the homework, right? We're going to make it more tolerable. Unfortunately, while these things are done with the absolute best of intentions, they're actually fueling the fear. Some people are more visual. Oh, there it is. This is a poster I have in my office illustrating this same concept. If you want to blow up a fear, if you want to make it bigger, fuel it with avoidance. Okay, so let's talk treatment. This is where the information that I'm giving you will hopefully lead to some useful tools as parents. So the American Psychiatric Association has come up with expert guidelines for OCD treatment. These also apply to anxiety disorders. Their expert guidelines are exposure with response prevention. That's the therapy I'm going to talk to you about today, and those are the tools that I'm going to be teaching you. Okay, it's a type of behavioral therapy. The American Psychiatric Association is a bunch of physicians. They do not do therapy. So it's pretty impressive that their first recommendation was therapy, not medication, because medication is sort of what they traded. Now, they did say medication is sometimes indicated. You may have heard of SSRIs like Prozac, Lexapro, Zoloft. Those tend to be used for more moderate to severe cases. That's their recommendation. But they say that your child is always going to need some kind of exposure with response prevention therapy. Exposure means progressively and repeatedly facing your fears. This is the opposite of avoidance. And response prevention means resisting the urge to use compulsions. Remember those safety behaviors, those things that we're doing to feel better, like having mom come to school with us or washing our hands. So we're going to have to do some scary stuff and resist the urge to use the things that we use when we feel scared. So let's walk through some examples. Contamination OCD. I'm going to touch some surfaces, rub my hands together, and then I'm not going to wash my hands. And hopefully one day we're going to work up to licking our fingers and eating some germy foods off them, right? But again, the idea is exposure is touching these items. Response prevention means not washing my hands. I'm not going to go home and take a shower. I'm not going to use hand sanitizer. Emetophobia, so I have a fear of vomiting. And let's just pretend I've stopped eating milk with cereal because I think milk will make me throw up. So now I'm going to actually have to drink milk. Right? That's the exposure. I could start small. And then I'm not going to use anything to settle my stomach. So it's not drink milk and then take some ginger supplements, or drink milk and then take a Zantac. This is just going to be drink milk and see what happens. That's that response prevention. And then violent harm thoughts. People always get so scared by the idea of exposure if someone has harm thoughts. We're not actually going to hurt anyone. We're just going to go into situations that trigger these thoughts. So remember, I gave that example of the young guy who doesn't want to be with his brother because he's afraid he's going to strangle him. Well, let's let him spend some time with his brother. The thoughts are not really predictive of anything. They're just nonsense that the brain has generated. So we need to get used to being around the younger brother, having these thoughts, and seeing that, in fact, nothing's going to happen. Oh. What happened? Okay. So people come into the office, I give them this pitch, and this is usually pretty much how they see it. You've got anxiety up here, you've got time over here. When I tell people they're going to have to face their fears, especially young children, they tell me I can't do that. If I touch the surface and I don't wash my hands, my anxiety is just going to keep going until I explode into a ball of panic. Right? That's why I avoid it. I run from the situation. If I get scared normally, I touch this, and I run from the situation. Now, of course, with germs, it's hard to run from germs, so they use sanitizer. That's how they're running from it. Or if I'm scared of these thoughts, again, I can't always run from the situation, but I may try and ask, my parents if I'm okay, get reassurance. I run from the fear, basically. So that top line is what people think will happen, and then this line right here, this is what people are used to. If you get scared, you run away. And what actually happens is this middle line. That if you do things that cause you fear, your anxiety will go up. That's not just your feared outcome, that is what will happen. Your anxiety will go up. It's scary, it's unpleasant, but after a while it reaches a peak and it starts to pass and it actually comes back down. And you don't need to do anything to make it come back down. You don't need to start doing relaxation exercises. You don't need to do a compulsion. You don't need to do anything except wait. This is the secret to exposure therapy, and it's a secret, unfortunately, not a lot of people know. Now, I felt really good when I made this chart. I thought it perfectly illustrated how exposure works. And I started showing it to some people, and they said, well, yeah, that's all well and good, but it seems like you should just keep running from the situation because your anxiety goes away so much faster. Good point. So, chart number 2 was introduced. This shows what happens with repeated exposure. So the other example I gave you was a single incident. But this shows if you do the same thing over and over. So, again, we're going to touch this, rub our hands together and not wash. And the first time we do it, our anxiety is going to go way up. This person hits a 9 out of 10. Starts at an 8, goes up to a 9, right? Goes up first. And then it kind of slowly works its way back down, all the way over here. And I think we've reached, 1 by the end? And then exposure number 2 is the line underneath it where it's just the tiniest bit easier, but we still hit a 9 on exposure number 2. So even though the peak is just as high, it's slightly easier, and again, time passes, and we reach the end. And this time we actually hit a 0. Exposure number 3 is the line underneath that. I don't know what color to describe these in this slide, but you can see they're just getting a little bit easier each time the child or the adult does it. Really doesn't matter. Each time the anxiety is going up a little bit, and then it's slowly coming back down. This time marker, this is generally considered to be about 2 hours. So by 2 hours, the person usually has reached baseline, but it doesn't take 2 hours to feel better. Oftentimes you see a change within 20 or 30 minutes that the anxiety's come down, but it's still not past. Yes? So I think the question is, given that we need to wait out this anxiety, how much training is involved to help parents help the child wait out the anxiety rather than rushing in with a compulsion or a safety behavior? Yeah. So great question. A lot. I mean, in some sense, sometimes I sit down with parents, I explain this to them, and that's it. And other parents are coming in week after week, and we're having the same conversation. It's very tough because, as I imagine your question is about, is that the emotional side of watching your kids suffer is very hard. And so sometimes parents do need a lot of coaching and a lot of reassurance of their own that, this is what's needed. This is how to be helpful. So yeah, it's tough. It's absolutely tough. It's a good question. Okay. I don't want to get too bogged down in theory. I was told not to do that, but I think you kind of need to know this part, especially if you're going to be helpful with your kids. This therapy, exposure therapy, is based on learning. Basically, anyone who says, I'm willing to do exposure therapy, a child who says they want to do it, an adult, they're saying, I'm willing to learn something new. And they're going to learn at a minimum 4 things. The first one is if I stay in a situation that scares me, the feeling of fear will eventually go away on its own. I don't need to do a compulsion for the fear to pass. That was so much more satisfying. That was this one, right? This is what they're learning. Right? Is that if I hang out, if I stick with it, if I do the thing that, boy, oh boy, I really don't want to do, it actually gets better over time. Number 2, if I repeatedly do this, then it becomes less scary, which was that second graph. Hey, that one was faster. Okay? Third one, this is the one most people think about when they think about exposure, is that horrible things rarely happen. So you actually don't get sick very often, even if you touch germy things. If you've ever spent any time with babies, they put every germy thing in their mouth and somehow they survive it, right? Horrible things rarely happen. Now that is important and it is a big part of exposure, but as you can see, it's only one small part of this. Okay, a big part of this is not just learning that germs are okay and that school is okay. It's learning that I can handle feelings of fear, which is number 4. Even though facing my fears is very scary, I can handle these feelings. So you see, we have to do exposure to learn all these things. We have to be in situations that scare us, right? And this is why avoidance, unfortunately, fuels fear, because it prevents you from learning these things. In fact, it teaches you the opposite, right? You're scared to give that presentation. We don't think you can handle it. We don't think you can overcome it. So we're going to let you not do it, right? And it seems very compassionate, but unfortunately, it has this very insidious outcome associated with it. So let's look. Hopefully I've persuaded you that maybe you're thinking about trying to help your kid with some exposure, trying to help them face some of their fears. Okay? Now, one of the biggest barriers people run into is that they kind of think, oh, okay, I have to learn something new. I can just explain it. We can just talk about it. Right? I'll sit down, I'll tell my kid, it's okay to touch that. You won't get sick, I promise. But if any of you have anxious children, you've seen that those kinds of conversations don't tend to lead to any meaningful long-term results because learning has to happen through experience. So it's not your fault. It's not that you don't know what to say. It's that we have to do it. You unfortunately cannot talk or think your way out of fear. Not in any meaningful long-term way. I understand, yes, with enough reassurance, you may calm down for a few minutes, but you're still going to be just as afraid the next time, if not more so. The other big error is that people try and block anxiety during exposures. This can happen through the use of substances. They may, take a drug that's supposed to block anxiety, or it can happen through reassurance, or virtually any other method. Just remembering a story someone told. Some friends of mine had learned about the work I was doing, and they were introducing me to someone else, and they said that I go in and I touch all these gross things in the bathroom, and then I lick my fingers. And when they were telling the story, they said, but he goes in and he bleach wipes the whole bathroom before he does it. I said, no, that's not what I do. That would defeat the whole purpose. And this is, I think, kind of talking about that same idea of like, make it safe, make it not scary. No, it has to be a little bit scary for it to work. So we can't block anxiety. Okay, What about relaxation? Relaxation is probably the number one thing I get called about. People always want their child to learn how to relax and calm down. Kind of makes sense. He's so wired up all the time. Unfortunately, relaxation has shown absolutely no benefit in the treatment of OCD or anxiety disorders. And they have tried every which way to make relaxation appealing through science. They said, well, what if we add it to exposure? Would that make exposure better? No, it doesn't. It makes exposure worse. And they said, well, maybe we'll give it to people who aren't ready for exposure, which is actually a fairly reasonable idea, but those people show no benefit from it either. Relaxation is just another safety behavior. You can handle this if you take some deep breaths. You can handle this if you tell yourself you're going to be fine. Those things sound reasonable. They make sense. They just don't work. It's another form of avoidance. So you may be saying, well, then why the heck is relaxation everywhere? Why is every book I read about childhood anxiety have a chapter on relaxation? Why did my child's therapist recommend relaxation? Why did my own therapist recommend relaxation? There's a very simple answer. It's fun. People like it. Unfortunately, healthcare is not immune to capitalism. It is a customer service field. People want it, so there's a market for it. But that doesn't necessarily mean that it's helpful. And in fact, we know very clearly that adding relaxation to exposure makes exposure less effective and take longer. Okay, this is why you're all here. What can you do as a parent? What are your tools? Unfortunately, ERP is tough. She asked this question about parent training. It's really hard to do ERP. So I really would recommend that you seek professional guidance through exposure with response prevention. A therapist is going to be, someone who specializes in this is going to be your best bet to help your child. However, there's a lot you can do to support ERP to get your child ready for exposure and to just change how you as a family approach anxiety so that when the therapist says, hey, you're going to have to face your fears, your kid says, oh yeah, that's what I always do. Instead of, no, that's not how it works. You're supposed to tell me how to relax, right? So let's talk about first, you could change how you discuss and approach your own anxiety as well as your child, so you can emphasize the importance of facing fears rather than avoiding them. So if we think about that child who's afraid to give the presentation, we could say, you know what, how can we help you give this presentation? How can we work towards that rather than, let me talk to the teacher and see if we can find a way for you to not have to do this, right? And that's tough and that's scary. And back to her question again, that's going to trigger your own anxiety and probably some guilt too. But it's going to be what's needed to be helpful here. Another thing we can do is start the process of eliminating all forms of accommodations. Accommodations are things that we do to help our child get through the day by avoiding their fears. Or you could say to help our child get through the day by feeding their fears. They provide short-term relief but long-term worsening in symptoms. So you can imagine, I'm trying to get to school, we're late, I have multiple kids, and my kid doesn't want to push open the door, so of course I open the door so he walks right through it so I can get on with my day and not be late to work. Makes a lot of sense. But then he didn't touch the door. We've accommodated the OCD, which is a problem. So we're going to need a strategy for this. You see this a lot in selective mutism. That's probably one of the more clear-cut examples of accommodation is the parent simply speaks for the child, right? Stranger or a teacher asks the child a question, the parent just answers for the child. This is an accommodation. It's done to provide short-term relief and to get through a very hectic and busy life. But unfortunately, it makes things worse in the long run. So we want to start chipping away at these. Modeling. I think modeling is pretty cool and important. And a lot of parents I talk to who have their own anxiety are always scared that they've passed on their anxiety to their kid. That it's sort of their fault their kid is anxious, or that, oh, I got so scared and I think I was just showing him to do this. And, maybe it's hard to say for sure. We don't know what causes it, but I don't think so. I think that you actually have a unique opportunity if you're dealing with some of your own anxiety. And even if you're not, you can pretend. Which is just, let's model facing fear. Let's model taking an approach of going towards scary situations. I'm scared to go to this party tonight. I'm scared that maybe there won't be anyone to talk to. Even though I'm scared, I'm going to go and see what actually happens. And I could tell my kid the next day, boy, it was really hard, or yeah, I met a new friend. Right? We can model this. Even if you're not scared, you could pretend. You pretend things for your kids all the time. My boss came into my office today, and for a moment I felt so scared like I was going to get into trouble. But it turned out she just wanted to ask me a question. Right? So we're modeling this sense of, what we think will happen isn't always exactly what happens. And that's an important behavior here. Scaffolding. Okay, using small steps to eventually build to a larger one. Okay, so here we have a child with separation anxiety disorder who has asked his parents to write a note promising that they won't die. May seem extreme, but actually quite common. Child goes to school and says, okay, I'm willing to go to school, but I need a safety behavior. Obviously, he doesn't say that. He says, I'm willing to go to school, but I need you to write a note for me that says you promise you won't die while I'm at school, and then I'll feel okay while I'm at school. Right? It's an accommodation, right? But, what are we going to do? How are we going to get out of this? If we say to the child we're not going to give him a note anymore, we're going to have a big fight, and we're going to struggle to get this child's buy-in to this new way of thinking. So what we want to do is scaffold. I can't write a note anymore promising that I won't die. First of all, you can't promise that. Hopefully you won't, but that's not a really reasonable promise. But we need to start facing this fear together. So I'll write a note saying I love you, or I'll write a note saying I'm going to try to stay safe today. How about we modify the note? We're going to take a small step, and then after that we're going to modify the note again, and then after that we're going to get rid of the note. Right? So we're going piece by piece, facing fears in a more manageable, tolerable dosage, rather than all at once. Okay, touching the doorknob feels too scary to you. What if I touch the doorknob and then you touch my hand with one finger? Okay, that's quite a bit easier, right? So we're scaffolding. No step is too small so long as we keep moving forward. It's okay. Maybe he spends an entire week just touching your finger, touching your palm with one. That's okay. You've all heard the phrase, life is short, but life is also long. You've got time. You've got time. We take 18 years to launch kids, usually. So it's okay. If he's 6 years old and he's just doing one finger, that's okay. He'll get to 2 fingers, and then 3, and then eventually his whole hand. And usually you see a big snowball effect, which is once the child sees that it works, they'll take bigger and bigger risks. But in the beginning, the risks can sometimes be very, very small, and it can be frustrating, it can be hard to watch. But it's important to put that time in because you're trying to persuade them of a new way of thinking. You're trying to show them that this works, this can help. Praise. Praise is a super effective way to increase any desired behavior. It plays a big role in anxiety disorders, or OCD. But you have to pay attention to behaviors. So what are the behaviors we're trying to increase? One is we need our child to tell us that they're scared. You can't help them if you don't know. 2, you need them to identify that their fear seems to be a bit different from how other people feel. And then 3, they need to be willing to move forward while feeling afraid. I will say, in general, I've almost never met a child who wasn't aware that their fear was different. Number 2, that identifying that the other people seem to be having different. Generally, kids already know this, so I wouldn't spend too much time worrying about it or praising it. It's going to be automatic. Kids are pretty smart. That kid walked into the door and didn't seem to be bothered. I walked into the door and I can't touch. These things are pretty obvious. But number 1 and number 3 are going to be much harder, which is, it's okay. Telling them, praising them, it's good you told me you're scared. I'm glad you told me that. Right? And then, of course, moving forward, that's the exposure piece. Watch out. You don't want to praise your child for not being scared. It seems like it would be a good thing to do. But not being scared really isn't a behavior, and it's also something they have no control over. If they're scared, they're scared. And in fact, we want them to tell us. We don't want them to hide it from us. So we want to be very careful about this. You do hear this a lot. Oh, you were so brave today. I'm so proud of you that you went to school and you weren't even afraid. No. That's not a target behavior. Going to school is a target behavior, but not being afraid is not one. Okay? Let's change how we talk about goals and progress. The goal is to consistently move towards anxiety instead of away from it. This is the short-term goal. If you do this, you always win. It works. It will give you what you want, which is a long-term reduction in anxiety. And of course, you come to therapy, you come here, you read these books because you want to give your child a long-term reduction in anxiety. That's your long-term goal. But if you focus on it in the short term, it's going to be a huge problem. This happens all the time. I don't know if this therapy is helping. He did this thing and now he's really scared. Oh, that's perfect. That's the goal. That's what we want. So it's hard, it's a totally different way of thinking, but it's important. Try to discuss and practice experiments or tests with your child. You want to become a team with them. Okay? So if you're scared that you eat pizza, you'll throw up, how do you think we can test this idea or start to test this idea? There's that scaffolding again. Okay, he's not going to eat the whole slice. Could we try one bite and see what happens? See if you throw up after one bite. See if you get nauseous after one bite. Okay. If pizza makes people throw up, what happens if I eat the pizza? We're taking this curious stance and trying to start doing some experiments. We're kind of turning our life into a science lab. If you have any kids who are into science, they're going to really get a kick out of that. If not, they'll learn something about science. You're saying that if you don't snap your fingers 30 times, then something bad will happen. I wonder how we can test this idea out. All right. And last one here. Let's see. So if you don't tap the phone with your left hand after tapping it with your right, then you think that you won't feel right, and that feeling will last forever. That's a big one with these symmetry compulsions, is that it's this feeling that being off is going to last forever. Let's test it out. You think it'll last more than 30 seconds? You think it'll last more than 5 minutes? 6 minutes? 7 minutes? 8 minutes? You can always tap once we hit 8 minutes. So you're just running these little experiments to try and disprove some of the ways that they're thinking, but you're trying to do it in a way that you and the child are on the same team, rather than just telling them that they're mistaken about these things. More tools. Reward programs. Facing your fears is really tough. Kids don't really get it. Once I was working with a kid who had a fear of elevators. He saw absolutely no reason that this was going to be a problem in his life. Not going to be a problem. And he was like a really smart, highly motivated kid. He was clearly going to be something. And I said, one day you're going to work in a skyscraper in a big city. You're going to work on the 50th floor. How are you going to get to your office? He said, I'll take the stairs. He's a kid. He doesn't understand this, right? So rather than trying to convince him to understand this, we need to modify a little bit and sometimes use rewards in the same way that we may use incentives with adults. Small rewards are best. You don't need huge rewards, and it's going to drain your resources if you do that, and it's just not going to be effective because your child's going to have to do so many exposures that you need to base out your rewards, but they should be desirable. Free or inexpensive rewards are best. Privileges, one-on-one time, candy, toys from the dollar store. I have a giant bag of M&Ms in my office, and it's usually just one M&M for each step of the exposure. Honestly, it lasts months, even though I'm doing exposure all day, every day, because it's like this palm full of M&Ms for each session. So you get a lot of mileage out of something pretty small, and the kids are pretty excited about it. You can add a larger reward too if you desire. Sometimes kids want to go to Disneyland or they want a video game system, and you feel like that would motivate them because you know your kid better than I do, and I think that's fair. But let's use those in addition to smaller rewards. So it's like if you get enough of these toys from the dollar store, or after you do 100 of these, then you get it. You need both. You need some short-term gratification. Kids, again, it's that idea of the skyscraper. It's just too far in the distance. It just doesn't work. You need some things that they can get today if they do the exposures. And you want to always give the reward if the child did the requested behavior. It doesn't matter if they get anxious or upset or if they cry or if they storm off. If the agreement was, you touch this, you get an M&M. If you touch this, you get an M&M. Doesn't matter if you swear afterwards or you say a naughty word. We can change the rules on round 2 and say from now on you only get an M&M if you touch this and don't say a naughty word. But on the first time, you need to follow through on the agreement you made with the child. They're doing something really scary, and it gives them a sense of control if you did what you said you were going to do, rather than, oh, well, there's some other rules I forgot to mention, even though some of those rules may be implied and other adults might have picked up on them. Your child might not have. Okay, validation and empathy. These are easy. Even if you don't decide that you're ready for exposure, you can always validate and empathize with your child. Just acknowledge that your child feels afraid and that it's only natural to want to avoid and escape. Encourage them to move forward anyways. But it's okay. A lot of times people are worried if the child says, I'm scared to go to school, and I say, yeah, school can be scary. People are worried that I'm sort of teaching the child to be afraid. But actually, that's not really true. I'm just reflecting what the child said. School can be scary. I'm not saying it has to be scary. I'm not saying he's going to die. I'm just saying, yeah, it's okay to be afraid sometimes. But school's part of life, so we got to get you there. How are we going to do that? Approach anxiety with curiosity instead of a right and wrong mindset. Right and wrong mindset is this idea of there's nothing to be fearful of. Why are you afraid? That's silly. That's irrational. That's a right and wrong mindset. But when we approach with curiosity, it's just more like, what is this like? What does it feel like in your body? I know when I get scared, my stomach hurts. Does that happen to you? Sometimes my heart pounds. Do you feel that? What does it feel like? Is your heart pounding right now? What are the thoughts that you're having right now? Kids generally around 6 can start to talk about their thoughts. They understand them as pictures or words that go in their head, but they know what they are. What are your urges? Urges is a word a lot of kids don't know, but they understand very quickly. It's something you want to do, right? So, okay, we touched this. What are your urges? Well, now I feel like washing my hands. Okay. How strong is it? Rating the anxiety. You can use a 0 to 10. You can use a low, medium, high. Or, kids are fun. They'll do whatever. Oh, I'm as scared as that chair. I don't know what the heck that means, but it means something to them. So, okay. It's funny because as I start to do exposure with them, it's like, oh, well, now I'm only one leg of the chair. And now I'm the little thing on the bottom. So they create their own scales, and that's fine because it's just a curious way to explore and talk about this. Instead of a don't feel that way, it's more let's become a team and figure out what's going on. Okay, final slide. This is it. You can discard everything else I said. This is the whole point of the work that I do. This is how you help people with anxiety disorders. Your comfort zone is all the way over here in this tiny little corner. And unfortunately, where all the magic happens is nowhere near it. If we can change our mindset a little bit to be that way and start thinking about approaching that and trying to grow the comfort zone big enough to fill up our lives, then we can really help kids quite a bit rather than trying to fit our entire lives into that tiny little comfort zone. That's my speech.